Hi, welcome to TCTMD. My name is Mamas, and it's my pleasure to introduce Professor Ole Frobert from Örebro University, who will today talk to us about his ESC late-breaking trial, the influenza vaccination after myocardial infarction trial, the IAMI trial. So welcome, Professor Frobert.
Thank you very much, Dr. Mamas, and thank you very much for having me.
So Ole, tell me, there's a lot of discussion, a lot of interest now, particularly around vaccination in the COVID-19 pandemic. Why is there an increase in cardiovascular risk after getting an influenza infection? What's the data to support this?
Yeah, it's actually old news. It was observed already in the 1930s when an American statistician looked at autopsies from various influenza epidemics and could see that many of the people that died from influenza actually died from heart conditions and quite often from myocardial infarction. And then there have been studies, of course, in the area, a huge number of observational studies, both on vaccine, but also on influenza and cardiovascular risk. And then there are three smaller single-center randomized trials comparing influenza vaccine with no vaccine or with placebo, all showing a reduction in cardiovascular events with influenza vaccine.
And do we know anything around the timing of this increased risk? I mean, is it a constant risk? Is the risk much higher, closer to the infection? How does the risk relate to the timing of infection?
I think there's not complete agreement about this, but the newest meta-analysis in this area, both by Udell and a newer one this year in the Journal of the American Heart Association, have shown that if you're close to an acute event, there seems to be a better effect from influenza vaccination. And also if you are at a higher risk, but that's of course interrelated.
Yeah. And do we know much about the mechanism and why does influenza increase your risk of myocardial infarction?
What we know is that if you encounter influenza, the more basic parts, of course, you have fever and tachycardia, and that, of course, leads to increased metabolic demand.
Yes.
Also, influenza is associated with a proton-bodic state. There is an increase in cytokine production, and there are quite convincing animal studies showing that with influenza disease or in illness, there is a risk of plaque rupture. So that's what we know, but a lot of this, of course, is experimental, and we don't know for sure, but we know that influenza virus is more severe cardiovascular-wise than many other upper respiratory viruses.
So, I mean, the AHA and the ESC both recommend vaccination with a class 1B indication. So what's the evidence gap that we're addressing with the IAMI trial? How is it different to other trials that have been run in this arena?
In my view, the recommendation is, of course, correct, but it's not really based on hard data. Yes. And I think when you ask most cardiologists, perhaps they inform patients, oh, it's good for you if you take your seasonal flu shot, but who is going to give it? Is that primary care or is it patient's initiative? Nobody really knows. And that's one aspect. The other aspect, also what we've seen from our trial is timing, when you'll have it. So when we discuss our results more in detail, I think it's quite safe to say that perhaps it's time to leave this responsibility with cardiologists. Of course, that's quite controversial. Sorry. Yeah.
So just maybe perhaps run us through how the trial was structured. What did you do? How did you structure the trial?
Yeah. So IAMI was an international investigator-initiated, multi-center, randomized controlled trial. It was a pragmatic trial. We enrolled patients at 30 centers and across 8 countries in both the southern and the northern hemisphere, and that's important when we talk influenza. And patients were enrolled between October 2016 and March 2020. Our inclusion criteria were quite broad, so we enrolled patients with STEMI or non-STEMI, or with high-risk coronary artery disease, patients over 75 years of age, and at least one additional risk factor. Also, an invasive evaluation was an inclusion criterion in all countries except for Bangladesh, because in that country it's simply not part of standard care. And then we excluded patients who had already been vaccinated during that current study flu season, and also patients or planning to be vaccinated. Of course, we also excluded patients who were allergic to influenza vaccine and the components of that, if they had ongoing infection or if they were immunosuppressed. And in total, we enrolled 2,571 patients, and the inclusion goal was 4,400.
Yes.
But then came COVID, and in April last year, the Data Safety and Monitoring Board decided to recommend holding of the trial. The DSMB expected transmission of influenza to go down, and that turned out to be correct, but also that participants were at risk of encountering COVID, and that would be difficult and make it difficult to interpret results. So we ended up with 58% of the population that we had anticipated. The main outcome measure of the trial was all-cause death, MI, and stent thrombosis as a composite endpoint.
Yes.
And then we had some key secondary endpoints: all-cause death, cardiovascular death, myocardial infarction, and stent thrombosis. And we used a hierarchical testing strategy, so we were allowed to test for these endpoints in that order if the primary endpoint was significant.
I see. And so the timing of the influenza vaccination, I mean, that's quite important. I mean, I believe that you did it within 72 hours of the myocardial infarction. Why did you choose that timing rather than, say, a week or 24 hours? Does it matter?
I think the original decision was it had to be logistically feasible, but also it was a compliance issue because we wanted to do it while patients were still in the hospital. We wanted to test if that was safe, and it turned out it was. There was no difference in adverse events between groups. Only injection site reactions differed, but there were no differences in systemic events. And compliance-wise, I think if we could prove that this works, then we have a tool for cardiologists.
Yes. So what were the main findings of the trial? Because I think these are really quite important and more practice-changing.
Yeah, thank you for that. So over the 12-month follow-up, the primary outcome occurred in 67 participants in the influenza vaccine group and 91 in the placebo group. And that translated into a 28% reduction in the primary endpoint, the p-value of 0.04. And concerning key secondary endpoints, also cardiovascular death and all-cause death were both reduced, and by an impressive 41%, and even lower p-values, while there was no statistical difference in myocardial infarction.
Did that surprise you? Because it sort of surprised me when I was looking at before I saw the results. I was expecting that you'd probably see a reduction in myocardial infarction, perhaps cardiovascular death, and yet, you see no effect on MI.
I think it's not very easy to explain, but it's almost on the digits, complete the same that has been found in the most recent meta-analysis. Of some reason, maybe it's a matter of the mechanism, or maybe it's a matter of size, of number of subjects, but the most recent meta-analysis showed the exact same. So decrease in the very hard endpoints, but not in MI, not statistically.
Yes. Now, one of the interesting things is that the study from the protocol, it appears that you only recruited patients during the influenza season, so between October and March. What made you do that? What should we not be doing in line of your results? Should we not be giving influenza vaccination at any time of the year?
Yeah, you're correct. It was only during the influenza season, and just to be completely clear, in the southern hemisphere, that season was between April and September.
Okay.
So we have that in place. But that was what the vaccine was approved for.
Okay.
I'm not sure there are studies, perhaps there are, on giving influenza vaccine outside of seasons. Had we known the results, of course, we would have tested that.
Yes.
Because this start-stop sequence was, of course, also difficult. Influenza vaccine needs to be handled in a cold chain, and there are lots of logistical issues with conducting a study like this. We didn't know that, but let's see if we or others would encounter such a study.
I mean, so I guess, my next question is, where does that leave, practicing cardiologists like myself? I have a patient now that comes in August. Should I give him or her the influenza vaccination?
Of course, it's a very sympathetic thought, but I think I'm a little bit rigorous when it comes to evidence. And I think we didn't test for that. So I think that the best thing to do in such a case is simply to recommend the patient to really get the vaccine when it's available for that next season.
Yes.
That's what we know.
I mean, I guess the other positive thing is looking at your subgroup analyses, there seems to be consistency of effect with different influenza waves, and that's quite important. Did you see similar efficacy in the different regions that you studied?
Yeah, we didn't see any differences in any of the pre-specified subgroups. There was nothing that came out and showed interaction. And then because we enroll patients in very different countries in many aspects, we also, and that was outside the pre-specified protocol, we also tested for interaction between countries, and there were none. So it was very consistent all way.
Yes.
Yeah.
So, I mean, I guess we can talk about some of the challenges that you faced during the trial, because I know that you changed the inclusion criteria during the trial because of poor recruitment. So perhaps you can talk to us about why was it so difficult to recruit patients into this trial?
I think the population that we were approaching were a population of patients that would usually not have influenza vaccine, and perhaps they never had it in their life before. So we have to convince these patients that this was an important study and they would actually accept vaccination just after having experienced myocardial infarction. So that was a threshold, of course. And as we know with COVID vaccine, some part of that patient group, of course, had skepticism to vaccination. So that really was a challenge. And then we added this group of stable patients, high-risk stable patients, but totally we only enrolled 8 of these. So yeah, in retrospect, of course, we shouldn't have done that, but we were quite desperate to get inclusion up.
And I guess the other change to protocol was that it was a registry-based trial initially, or in the methods paper, particularly in Sweden, where you have a great history of running these sorts of registry-based randomized control trials. But then you moved away from that for some of your participating countries. So perhaps you could talk to us about that as well.
Yeah, again, that was a completely just a practical aspect, because we had to broaden the trial outside of Scandinavia to meet our inclusion goal, which was perhaps a little naive. We thought we could do this in Scandinavia only. So we had some great centers in other countries that did a fantastic work, but we did all follow-up outside of registries. So we only included baseline information from registries in Sweden and 3 out of 5 Danish centers. So that was what we used them for. But I think it was important that we were flexible and could continue to get where we got.
I guess one of the things that I have to talk to you about is COVID. You know, everyone's talking about COVID, and it's really around implementation of this, the results of this trial during COVID. I mean, you know, we're going to have COVID probably for the next couple of years at the very least. You know, how relevant is this trial now in a new era? I mean, when you started this trial, we'd never even heard of, you know, this.
Yeah. I hope that it will make people, the general public, more aware of the importance of vaccination in general.
Yes.
And perhaps some who have received COVID vaccine will now understand how important also other vaccines. I think that's really an important issue. And then there have been reports now, almost a year ago, the first came out, that you can have influenza and COVID-19 at the same time.
Yes.
So, of course, the cardiovascular risk profile is different if you have COVID-19, but you really don't want to have both infections.
Although, interestingly, in quite a few countries, including the United Kingdom, we've noticed that influenza rates, particularly last year, were almost zero because of the mask wearing, social isolation, and so forth. So do you think that, you know, influenza and cardiovascular related mortality is going to be relevant, say, in the next few years?
The short answer is a yes. And
okay.
Two notes or points on that. One is that in our study, a little bit surprising also to us, is that we saw the separation of event curves starting very early in the first few days. And we were really surprised by that. But then while writing the study, there came out a very interesting study from the US on eligible CABG patients awaiting coronary artery bypass. It was only 30 patients, but 15 were allocated to influenza vaccination in the week before the operation, and 15 had placebo. And what they found was quite impressive. Again, only 30 patients, but in the vaccinated group, inflammatory markers were down by half, and the same with troponins. It's a stretch to talk about a pleiotropic effect, but of course that's what we are thinking. But it's important, of course, not to overinterpret our findings, and we shouldn't be the ones doing it.
And you have a serum sub-study as well, as I understand.
Yeah, I'm sorry, but we had to close that because it was so much work, and I think we enrolled 10 patients in that. So no, we didn't get that in the box. I'm sorry.
Okay.
But it would be most relevant.
Yes. Well, I think, you know, this is a really important study. I think it really is relevant. I think that particularly now during the COVID-19 pandemic, I think, you know, as our minds as cardiologists have really become focused on vaccination and the importance of vaccination during these pandemics and their impact on cardiovascular events. So I'd like to thank you for sharing the results of your study, and also like to congratulate you on your late-breaking trial, because I think it's a really important study. So thank you, Ole, for joining us.
Thank you so much, Mamas, for having me.